Welcome to the third annual Surgical Resident Research Day presentations. This is becoming an event that I look forward to, at least, to catch up on what's going on in the department with residents, faculty, research, learn a little bit more about the interests and passions of the staff, and also see that the department is heading in the direction that I sort of want to take it, and that's toward a more academic, more scholarly environment. I think the program today is an excellent program that really does illustrate the strength of some of the research programs. And again, I'd like to emphasize that some of the research that's presented here today is research that's done outside of Tufts and other institutions by our residents, but our goal is really to bring as much of that research back to Tufts as we can and develop our research capabilities within this department and in our collaborative departments, medicine and other areas where there's a lot of research going on, that we have the opportunity to work with those departments and build stronger programs. So again, my thanks to Reuben for organizing this, and Julian for his role. He's been a stalwart in this over the last couple of years. I think you'll enjoy the program. Hope there will be plenty of time for questions so that people can get fully engaged in this, and I hope that some of the younger residents in here will be inspired to start some projects of their own as a result of today's activities. Thanks very much. Reuben.
Welcome all. Yes, please.
Just click this on your belt.
Welcome all and good morning. As you know, research is one of the major efforts in our department, and I'm not going to extend much on that. And before I start, I want to thank three individuals. Beth Wolf, our new research coordinator for the department. I want to thank Annette. Where is Annette Cerulli? Not here. Well, I want to thank her. And I want to thank Julian for their contribution and their help in making this happen. So this academic year has been a good one for our department. There's evidence in the multiple presentations and publications generated here, which you can now see in the brochure in front of you, and also online through the research website that we are going to launch today. But it was also a good year because we established and starting implementing a new research development plan for our department. And I'd like to very briefly describe to you the essence of the plan. It has two major aims: to increase funding, of course, for research in our department, also and in parallel to increase the number of research projects, publications, presentations, and basically to upgrade the stature of our department as far as research is concerned in the surgical community. So to that end, we first identified funding sources and collaborations. And this again is an evolving project, but we have identified many general and specialty specific external as well as internal funding sources, and we put them all for your convenience on the website. We have established what I call a funding information resource, FIR, in which if resident X want to do research with specialty Y, he can click and see all the available funding sources for that specific interest. We also now mandate, as of the next academic year, scholar activities by both attendings and residents. We ask at least one annual peer-reviewed publication or book chapter or review article or editorial by each individual. Also, the same thing for abstract submission to either regional, national, international meetings. As far as the PGY ones, we give them a break the first year, but we ask that during this year they identify a mentor whom they can work with to generate papers in the years to come. We also established a research registry for the department, and I'll present it to you shortly. And the idea is to store and make available all the research efforts and project and interests and the bios of the researchers in our department. This is going to be a dynamic entity. We ask that whenever you publish anything or presented in any meeting, one of your papers, that you shoot us an email and so we can update it. Regardless, every 3 months or so we will send you an email soliciting for this information. This will allow everybody to know what's going on, but it will also allow the chairman to monitor the compliance of everybody with the requirements that we set forth. We also established formal relationships with the CTSI statisticians, and there are multiple papers now in our department that are done in collaboration with the assistance of this group. We also are going to dedicate some of your Thursday morning lectures to try help you understand how to write papers, how to read papers, etc. And lastly, we are going to select 2 liaisons from one PGY4, one PGY5. And for next year, the PGY5 is going to be Julian, and the PGY4 will be Andy. So when Julian graduates next year, we'll have to select a new one. So that's how the rotation is going to be. Now, what I want to do now is introduce to you our research website, which is available as of today on the intranet, and shortly will be available on the internet as well. This is open knowledge. We should all be proud of what we're doing here. So I'll just give you some demonstration. So this is a home page. You can see we have several buttons. This is a research registry I talked about. This is a FIR, the funding information resource. There will be a newsletter probably every 6 months that will outline the research achievements for the department. This will be a summary of our research day. Every year, of course, we'll update it. Then we have the surgical laboratory here, and that opens the window for a lot of studies, especially large animal studies. There will be frequently asked questions, the relevant links, and lastly, statistical analysis. It gives you links to very useful websites in which you can use to do your own statistical analysis. So I'll take you through this very briefly. So we start with research, with the research registry. I'm connected, I hope, online. So we'll click on the research registry, and you can see it goes by department, by division, each division. So I'll just take, for sake of demonstration, the first one, acute care surgery. And this is similar in any division that you open. You'll see the current research, you'll see publications, you'll see presentations, and you'll see the researchers. So we'll start with current research. Click on that. You can see the list of recent publications. Then you can go or to the home page, or you can go to the prior page. If you want to know a publication, similar. If you want to know the researchers, So you can see it goes by researchers. So we'll go Stan, is he here? Anyhow, okay, so you can see his bios, and it's the same template for everybody. So if you click on Julie Kim or Roger or whoever, it's the same template for everybody across the board. Now we'll move on to the funding resource. So again, it's by division. So let's take plastic surgery. Okay, so you can see the various funding potentials here. So I don't know what it stands for, but we'll find out. American Society of Plastic Surgery and Plastic Surgery Foundation. You can click on all the links and then look for yourself what suits you, and then consult with Dr. Driscoll whether you have a chance, or he can instruct you to how to proceed with this. So this was as far as the funding opportunities. The newsletter is still empty because we're just starting, but in 6 months there will be one. The annual research day, you can see we have all the abstracts submitted and presented, in fact presented at the 2012, 2013 and the current one. So let's click on 2013 and you can see all the presentations there. This gives you the link to, as I told you before, surgical and interventional research laboratories. Some of you I know are already working within this laboratory. Some frequently asked questions: how do I place a request to help my IRB application or research project, for example, and then the links that follow. These are just useful general links from American Heart, the IRB, for example, and others, including the NIH. And the last one is statistical analysis. These are really useful links. They are free, and you can. Most of them are user-friendly, and you can just plug in your data, and you can do your own statistics until a certain level, of course. And the last part of my short introduction is to present a program to you. So we'll start with Dr. Farsad Newberry here with us, who is a senior statistician at CTSI. He's also an assistant professor of surgery and is deeply involved in teaching and assisting clinicians and others in their scientific and research efforts. He will talk about, or the title of presentation will be Evaluating Observational and Experimental Research Studies and Methodological Perspectives. The idea is to give, especially the residents, also the medical students, some basics, concepts, so they will be better prepared to read, certainly, and hopefully to write papers in the future. Then there will be 5 presentations for the competition. The papers will be graded by 3 of the senior investigators here in this department, and then there will be a prize for, of course, for the winner. Each presentation 8 minutes. Julian, you are the clock keeper, so please be tough. And followed by 2 minutes of questions. And then the intention was to have 3 short presentations, each 3 minutes, no questions asked, However, Sarah unfortunately had some emergency, and she pulled out her competition paper and her, of course, her short presentation as well. So we have, unfortunately, since it happened less than 24 hours from now, nobody could have prepared a short presentation. So we'll have only one short presentation. This will be followed by something new, which I called Research Market. This is each division chief or his or her designee will, in 2 minutes and several slides, if he or she wishes, present to you, to the audience, their research activities, their research projects, the publications, the productivity of their respective division. 2 minutes each, really just the essence. And the idea is to, again, give everybody the knowledge of what's going on with the department, and for residents who are soliciting mentors or residents who want to do research, they will know where to go. And lastly, also, although not directly related to research, but given the feedback that I got from last year, I continued the quiz competition. There will be 10 images. There will be 1 minute to respond and 1 minute for explanation of the right answer. The competition will be between the fellows, PGY 5s and PGY 4s. I don't know if we have enough fellows here. How many? Because if we don't have only one? Okay, in that case, I suggest that you join the PGY 5s and we'll add the PGY 3s to the competition. So we'll have 3 groups to compete. So, without further ado, I would like to welcome our keynote speaker, Farzad Newberry. The floor is yours.
Okay, thank you very much for the opportunity to be here. So I'm just going to give a very brief and basic presentation about how to look at papers, kind of think about your own research as you get started. I know for clinicians, oftentimes the most daunting part of getting into research is the statistical analysis. So I'm here to tell you that there are many resources here at your disposal, and including the CTSI, which was mentioned, but we also have a master's and PhD programs in clinical and translational science, if that might interest any of you. We usually have 15 clinicians a year in that program. We have courses on biostatistics, epidemiology, and so on. Okay, so I'll just go through some very basic examples, things that you'll see in the literature when you read papers, t-tests, linear regression, and so on. And so oftentimes in research we're interested in comparing 2 different groups. So in clinical trials, in experimental research, that might be the placebo versus treated groups. In observational studies, that might be the exposed versus the unexposed. And so how do we go through that in terms of the statistical methods required? So the examples that I use come from multiple sclerosis. So we have 2 main forms, relapsing and progressive, and again, you can pretty easily translate this into your own area of research, just whichever 2 groups that you're looking at. And so the question here is immune system involvement different in the 2 forms of MS? And so the marker that we're going to use is this one called CD26, okay? And so importantly, this is a continuous outcome. And so when you're thinking about what sort of statistical analysis to do and how to analyze your study, you always want to think in terms of what sort of outcome variable do I have, what sort of covariates do I have, and then once you have those 2 pieces in place, that will determine the type of statistical test that you'll need to use. And so we'll go through some examples. And so the research question here is expression of CD26 different in relapsing MS patients compared to progressive ones? And so again, this outcome is CD26, and importantly, it's a continuous variable. The explanatory variable or covariate or independent variable, all these different names for the same thing, is the group membership. Are you in the relapsing group or the progressive group? That's a dichotomous or binary variable. And so we would naturally just collect samples from each of these groups and study them. Okay, so if we had done that, say for example, we get mean values of the CD26 marker in relapsing patients to be 37.4, in the progressive to be 44.3. And so we want to know, does this represent a significant difference between the two? Okay, and so oftentimes when we're looking at medical research, I think there's an over-reliance on p-values. People say, oh no, I didn't get a p-value less than 0.05, I can't publish my research. But we want to move away from that. Instead, we want to think about both, is it statistically significant? Can we show that there's a difference between the groups? But also, is the difference clinically meaningful? So don't overemphasize rather p-values and things like that, but instead keep your clinical knowledge in mind as well. So, but in order to answer the question of whether there's a significant difference between the groups, we need to measure the variability as well. So here we have the means for the two groups, but again, to determine if they're significantly different, we need some measure of their variability. And so to illustrate that point, here are two different experiments, one on the left and one on the right, again of the progressive and relapsing. And so these are histograms, box plots rather, that I'm sure you've seen. So you can see in the two experiments, the progressive groups have the same, the box plots represent medians, but you can assume that they're means as well. So they have the same means in the progressive group, the same means in the relapsing groups, but what you can see that's different between the two experiments is the amount of variability in the different patients, okay? And so even though we have the same means in the two experiments, we would get to a significantly different result based on which one we were in. Specifically, in experiment 1, we would be able to conclude that there is a statistically significant difference between the progressive and relapsing groups, while in experiment 2, we would not be able to make that claim because there's much more variability in experiment 2. Okay? So the means are the same, but again, the amount of variability, how different patients are, impacts whether we can show that there's a significant difference between the groups. So just to give you, the steps that you might go through to do your hypothesis testing, well, our null hypothesis here would be that the mean in the relapsing group is equal to the mean in the progressive group, or equivalently that their difference is equal to 0. And again, it's very helpful to go through this exercise of being very explicit about the types of variables that you're working with. So here, again, our outcome is a continuous variable. Our explanatory variable is dichotomous, which group are you in? And so now that we have these two pieces of information, we can determine the type of statistical test that we need to compare the two groups. So since we have a continuous outcome, a binary covariate, we can use a two-sample t-test to compare them, okay? And so there are all sorts of assumptions. Any statistical method that you use will have assumptions embedded in it. And so it's very important to check those assumptions so that your results are valid. Unfortunately, we won't have time to go through that here, but the assumptions are listed here, that the underlying populations are normal, you have independent observations, and so on. If you have repeated measurements on the same patient, for example, those would be not independent observations, and you would need other methods that account for that clustering. But here we have independent observations, and so in order to calculate this p-value that we so desperately need, we have to understand if the difference in the means is large relative to the variability. And so you can think of those two experiments, the box plots that we showed, where they had the same means, but the variability was very different. And so we use our statistical software packages to get this p-value. So again, to further emphasize this point, if you always think of what type of outcome variable do I have, is it continuous, is it ordinal, is it binary, is it a time to an event? And then you think about the type of explanatory variable that you're working with, and again, those examples are there. Those two pieces of information will then lead you to the type of statistical analysis that you need to conduct. Okay, so you can see there's all sorts of things here that I'm sure you've heard about: logistic regression and log rank tests for time to event outcomes and Cox proportional hazards models and things like that. But we'll go through some of the more basic ones, including the t-test and linear regression. So that was an example of a t-test. What if instead we have proportions? So here's a 2x2 table, sometimes called a contingency table, and we want to assess whether patients progress or don't progress, and whether that's related to whether they have a single nucleotide polymorphism or not. So we arrange the data in this 2x2 table. Did you progress or not? And did you have the single nucleotide polymorphism or not? And now that we have the data, we can go through and conduct our statistical test to determine whether there are significant differences in the rates of progression between the SNP positive and SNP negative groups. So how do we do this for a binary outcome? Well, what we typically use is a chi-square test. So let's illustrate how that goes forward. Okay? So if there was no relationship between the two variables, again, the two variables being did you progress or not, and did you have the SNP or not, what would we expect to see in the table? Okay? So let's use an example with easy numbers. So the way a chi-square test proceeds is we first assume that the margins are set. Okay? And so by margins, I mean the numbers that you see up there. We assume that those are given. What we allow to vary are the numbers on the inside of the table. Okay? So if there were no relationship between whether or not you have this single nucleotide polymorphism and whether you had disease progression, what sort of numbers would we expect in the middle of this table? Well, we would just take the margins and multiply them and then divide by the overall sample size. So you can hopefully see here what we did to calculate the expected count. Again, so what we're doing here is calculating the expected number of patients that fall into each of these 4 cells if there were no relationship between SNP and progression of disease. Okay, so what we do is we take the margin on both sides, multiply them, and then divide by the total sample size. So if there were no relationship between whether or not you have the SNP and whether or not you have disease progression, we would expect 25 patients to go in this cell. We can go through that same exercise for all 4 cells, and you can see the numbers that we would get. Okay, and so hopefully it makes sense, because if there were no relationship, again, between SNP and progression, we would expect 25 of the 50 SNP positive patients to progress and 25 of them to not progress. Similarly, 75 to progress in the SNP negative and 75 to not progress in the SNP negative. Okay? And so this gives us a table of expected counts, right? So we have our actual data, which tells us how many really did progress, how many really did not progress. And so we compare this to this table, which we've calculated, of the expected counts were there to be no relationship between these two variables. So let's do the same exercise for our actual observed data, which had a little bit harder numbers. And so here are the expected counts if, again, there were no relationship between these two variables. And so the question we're asking is, how different is our observed data compared to this expected table that we've calculated here? Okay? And so that's exactly what we're doing. We're comparing whether our observed table was different from the expected table, assuming that there's no relationship between the two. And so what we do is, you might think of, how would we calculate a test statistic? Okay? So O here stands for observed, and E stands for expected. So you might think, oh, in each of the 4 different cells that we have, we can take the observed minus expected and then add them all up. Unfortunately, that will just add up to 0, right? Because the difference between the observed and expected, if you add it across all 4 cells, you'll always get 0. And so instead what we do is we take the observed minus expected squared over the expected, okay? So again, you don't need to worry about memorizing formulas or being concerned about any of that sort of stuff, because the statistical software package will do that for you. Instead, what we're trying to do here is illustrate what's going on in the background when you do use these software packages. So if you're looking at binary data, as we are, binary outcome, binary predictor, and you're going to use a chi-square test, the test statistic that the software package calculates is the one below here. So it takes the observed count from your real data minus the expected, the table that we calculated, and then comes up with a test statistic that way. And so here's a little bit of output from Stata, one of the many software packages out there that you can use. And so you can see for this one, here's our chi-square statistic, here's our p-value, 0.319. And so for this particular data that we observed, we would conclude that there's no significant association between whether you have the single nucleotide polymorphism and whether your disease progressed or not. Okay? So again, just to hopefully not belabor the point, but again, to get you thinking in terms of how do I approach my analysis, you can always think, what type of outcome variable do I have, type of explanatory variable, and then that will determine the statistical test that you need to use. Okay? And so what about this comparison of experimental versus observational research? So we know that the key advantage of randomized clinical trials over observational studies is the randomization. Hopefully you're not surprised that a statistician is telling you that. So what does the randomization give us? Well, it ensures that the groups of interest, for example, placebo versus control, are balanced with respect to all other covariates of interest, gender, age, whatever else might be important. Okay? By randomizing who gets the treatment, you make sure that you have balance between the two groups in all other covariates of interest. And naturally, we don't have this very nice feature when we do observational research. We can have very unbalanced groups in all sorts of covariates. Okay? So let's, kind of a funny example. The New England Journal is usually not very funny, but the one time they did try to be funny, so they looked at chocolate consumption, cognitive function, and Nobel laureates. Okay? And so the key part of this short paper was this plot. Along the x-axis, you can see the chocolate consumption, kilograms per year per capita, and along the y-axis, you can see the Nobel laureates per 10 million population. And so you can see that there's a very strong association between how much chocolate you consume in a country and how many Nobel laureates there are. Okay? So you might conclude erroneously that if you just eat more chocolate, you're going to do better research, right? I wish that were the case. But what's missing here is, so this is observational data, right? This wasn't a randomized trial. They didn't tell certain countries have this much chocolate and other countries have this much chocolate. This was observational. And so there are other factors that are not balanced between these countries of interest, right? And so because of that, we need to do, in observational studies, we need to do multivariate adjustments, okay? And so again, whether it's gender, age, whatever unbalance there is between the two groups of interest, or three groups, whatever the number of groups of interest there are, we can adjust for these variables in our statistical analyses when we have observational data. Okay? So the statistical tests that we presented up to this point are called univariate tests, and that's because we're only looking at the relationship between one variable and the outcome. So for example, we looked at whether your group membership affected CD26, which was our outcome. So that was only one variable that we assessed, group membership. Similarly, we looked at whether SNP, whether having the SNP was predictive of whether you had disease progression or not. So again, we were only looking at the impact of one variable on the outcome. But in observational data, we need to do these multivariate adjustments. And so you can do that in many different ways. It's almost always in the context of regression. There are many different types of regression. We mentioned logistic regression. There's Cox proportional hazards regression for survival data. Again, this is always the type of regression that you do, again, is always determined by the type of outcome variable that you have. But if you have a continuous outcome variable, you can proceed with multiple linear regression. Okay? And so again, one of the big advantages of regression over t-tests and chi-square tests and things like that is we can include multiple predictors or covariates in the same model. And so we can then investigate many complex ideas such as confounding, interactions, and things like that. So let's think about an example. So suppose we'd previously investigated whether there's a statistically significant association between sex and BPF, and we saw that there was no significant difference between men and women in terms of BPF. We also saw that BPF declines with age. So we had looked at these factors independently. We first assessed sex and BPF, then age and BPF, but what if we want to control for these simultaneously in the same model? So, just to give a simple plot, here's our data. I was told that it's completely outdated to show males in blue and females in red, so I apologize for this outdated approach to showing the data. But again, you can see the age, the BPF, which is the outcome of interest, and the data shown here. Okay? And so the question might be, is age a potential confounder? Okay? So we saw previously that age has an effect on BPF. This has been shown in other research. We also know that male patients have a different disease course than female patients, so that age at time of sampling may be related to sex. Okay? And so sometimes you see plots like these. These are sometimes called DAGs, directed acyclic graphs. And so people draw these kind of theoretical constructs to then inform the type of regression model that they're going to fit. So this is obviously a very simplified example, but we're looking at the impacts of age and sex on BPF. And so here, age would be considered a confounder of this relationship between gender and BPF because it's related to both variables. So in a multiple linear regression model, we could include terms for both age and sex. And so it would look like this. Again, BPF is our outcome. The predictors are your gender and age. So again, when we put male there, females get a 0, males get a 1. We could parameterize it in the other way as well, as females getting 1 and males getting 0. It wouldn't make a difference in our results. And so then, again, the key is the statistical software package will do all the computation for you. What it will not do is interpret the results. Okay? So that's kind of our research focus, is how can we interpret these results? How can we fit the proper models? Okay? So usually we're not interested in beta 0, the intercept. We'll ignore that for now. So beta 1, if I go back again, beta 1 is this coefficient attached to the male term. That's the average difference in BPF between males and females at a constant age for the two. Beta 2, the coefficient for age, represents the average increase in BPF for a 1-unit increase in age, again holding gender constant. And so we note that the interpretation of our coefficients requires mention of the other variables in the model. So if we were to fit the model, here are some sample results. You can see the estimated difference between males and females is 0.17, I should say, holding age constant. Here's the coefficient for age. You can see for every 1-unit increase in age, the estimated mean BPF decreases because it has a negative sign, 0.0026 units. And so the next question we want to ask is, are these effects statistically significant? So to do that, we can go through these 7 steps of hypothesis testing. We state the null hypothesis. We talk about the type of data that we have, the type of statistical test that we'll use, and then these results come from our statistical software package. So here, for the effect of gender, the p-value is 0.37. It's a large p-value, greater than 0.05, so we fail to conclude that there's no significant association between gender and BPF controlling for age. We can go through the same exercise looking at age now, controlling for sex. We get a p-value 0.004. It's less than 0.05, so we reject the null and conclude that there is a significant association between age and BPF controlling for sex. Here's what it looks like in terms of stata output, just to give you an idea of what you might be looking at. So here's the estimated effect of gender, the p-value associated there, the 95% confidence interval, estimated effect of age, the p-value for age, and its corresponding 95% confidence interval. Okay, and so here's the kind of model that we fit to our data. So here's the estimated regression line for males. Here's the estimated regression line for females. The difference between the two is captured by that regression coefficient for male that we saw. And you might see here, hopefully as you're thinking about this and thinking about how we would take this analysis to the next step, you can see here we've assumed that the two groups have, males and females, have the same slope, right? In other words, we've assumed that the effective age is the same for males and females. That might be a faulty assumption. So we can fit a more complex model that includes an interaction term that allows the effective age to vary by gender. And that might be a research question. Does the effective age differ by gender? And we can assess that and test it statistically. Okay? So our conclusions from this kind of small study, although there was a marginally significant association between sex and BPF, the association was not significant after controlling for age. So you can think of this in terms of the chocolate example. It seemed like there was a relationship between chocolate consumption and Nobel laureates, but I bet if we included other variables, GDP per capita or whatever the case may be, we would find that the relationship between chocolate consumption and Nobel laureates would probably go away. Okay, just some final thoughts. So when you're reading research papers, always note how the study design, experimental versus observational, are the very broad categories, but there's obviously many subcategories within each. How the design impacts the statistical analysis that you need to use. And so the design and analysis must always be concordant. So here at Tufts, if you're trying to undertake research, you have to submit your protocol to the SRC, the Scientific Review Committee. And so oftentimes what happens is people will submit to the Scientific Review Committee, the committee will come back with comments, and then they'll come to us at the CTSI, and almost always, I can tell you, the Scientific Review Committee, their number one comment is your design and your analysis plan are not concordant, okay? So you have to always choose the analysis which is appropriate for the type of study design that you've proposed. And so hopefully you got some sense of the trade-offs between conducting experimental versus observational research. Experimental research is obviously the gold standard, randomized clinical trials, but it's much more difficult and timely and costly to conduct. Observational research kind of gives us insights, but when we're trying to develop a definitive link between things, that's when we undertake randomized clinical trials. Okay, so hopefully that was a good 25-minute crash course. And again, if you guys are interested in learning more, we have our master's degree in clinical and translational sciences through the Sackler School of Graduate Biomedical Sciences. Thank you.
Thank you very much. To condense all these statistics into 25 minutes is kind of next to a miracle. Thank you. It was a great presentation. Julian, why don't you take it from here?
All right, so I'll be introducing each of the speakers, and I'll give you guys about a 3 to 2 minute warning whenever it's getting close to the time, because I was told to crack the whip, so sorry. All right, so first up is Andy Benedict. He's going to be presenting work that he did with Dr. Schwalz in the PD department on CT scan utilization in pediatric trauma. Thanks.
I just want to add that the presentations are in alphabetical order.
So I'm not important. Good morning. Again, as Julian said, I'm Andrew. I would like to first off thank my mentors, Dr. Jackson and Dr. Schwalz, for their support of my work in their department. I'm very excited to discuss. Sure. So as I said, I thank my mentors, Dr. Schwalz and Dr. Jackson, for the support of the work in the department. I'm very excited to discuss my work entitled Utilization of CT Relative to Injury Severity Prior to Transfer for Definitive Pediatric Trauma Care. I presented this work 3 weeks ago at the Pacific Association of Pediatric Surgeons with Dr. Schwalz in Alberta, Canada. So unintentional traumatic injury continues to be the leading cause of death in the pediatric population. Many of these injured children are initially evaluated at referring institutions prior to transfer to a designated Level 1 or Level 2 pediatric trauma center for definitive care. Advanced trauma life support teaches that referring facilities should not obtain diagnostic studies of injuries if the facility does not have the capability to provide definitive care. Despite these recommendations, CT scans are often obtained during the initial evaluation of injured children at referring institutions prior to transfer to a pediatric trauma center. So referring institution CT scans has three major drawbacks. The first one being it delays in providing definitive care for injured children. There's also a risk of unnecessary exposure to radiation with an increased risk of malignancy. And also there's also a risk of duplication of the scans if the initial scans are either unavailable or inadequate, thus increasing both radiation exposure and healthcare costs. From our previous publication, this figure, which is figure 1, it outlines the triage criteria adapted from the Massachusetts statewide trauma field triage criteria for pediatric patients. And as you can see here, there are 3 physiological criteria, there are 8 anatomic criteria, and there are 4 mechanism of injury criteria. If any of these criteria are met for a patient initially evaluated at a referring institution, then there is data supporting that these patients should be transferred to a designated pediatric trauma center. And as you can see here, in looking back at our pediatric trauma database, we published that over 66% of patients initially evaluated with CT scans at referring institution had already met criteria for transfer to our Level 1 trauma center, making these scans relatively unnecessary. In addition, 10% of patients had 2 or more criteria in addition. So the purpose of our current study was to evaluate the relationship between injury severity score and CT scans performed in pediatric trauma patients transferred to our Level 1 pediatric trauma center. This was a 4-year retrospective cohort involving 422 patients transferred to our trauma center with CT scan imaging obtained at the referring institution as the primary outcome. This is Table 1, and shown in the top row, circled in red, you can see that patients who had CAT scans prior to transfer had significantly longer transfer times than patients who did not have CAT scans prior to transfer. Furthermore, on the bottom row, you can see that severely injured patients with an ISS score greater than or equal to 15 had a 3 times greater incidence of obtaining a CAT scan than severely injured patients who were transferred. This is counterintuitive. As you can see, more severely injured patients should be immediately stabilized and transferred for definitive care, and obtaining CAT scans delays that transfer and also risks increase in mortality. In addition, of the 413 total scans done at referring institutions, 110 of those scans, or 27%, had to be repeated at our institution. So in summary, the majority of severely injured children, those with an ISS score greater than or equal to 15, initially evaluated at referring institutions, were inappropriately subjected to CT scans prior to transfer to a Level 1 pediatric trauma center. Pediatric trauma patients transferred from referring institutions had significantly delayed transfer times to a Level 1 pediatric trauma center when compared to children who were transferred without any CT imaging. In addition, 110 scans, or 27% of the total performed at referring institutions, had to be duplicated within 4 hours upon arrival to our pediatric trauma center. There were 2 limitations of our study. The first, we did not have access to the records of injured children evaluated with CT scans who were not transferred to our pediatric trauma center. Therefore, we cannot fully evaluate the role of CT scans in children for trauma. In addition, the Massachusetts statewide triage guidelines used in our study were from the Department of Public Health, which were meant for EMS first responders to appropriately triage trauma patients. There are currently no statewide criteria for interfacility transfers of pediatric trauma patients to pediatric trauma centers. We hope that this study exposes the frequent and inappropriate practice of referring institutions in obtaining CT imaging when a majority of patients already meet criteria for transfer and care at a designated pediatric trauma center. and we hope that this can be used to provide a framework for a more standardized approach to evaluate injured children at non-pediatric trauma centers. Again, I wanted to thank Dr. Schwalz and Dr. Jackson for the support of this project, Leslie and Victoria from the Kiwanis Pediatric Trauma Institute for the support, and Jessica Paulus from the Tufts CTSI for her help with analysis. Thank you, and I'm happy to take any questions. Dr. Graham.
One question about the data that I may simply have missed. When you listed the ISS greater than 15, I read that as 10% of people had CT scans that were done prior to transfer.
Yes, severely injured showed 10% of patients.
And look at your summary statement. It says the majority of children with inappropriate distributed CT scans. I don't think of 10% as the majority. So I'm either missing something.
Sorry. So it should be some severely injured children were more likely to get CAT scans. Severely injured children were more likely to get CAT
So not
scans.
even close to a majority. 10% is a pretty small fraction, in fairness.
Mhm.
The other question I had is, we often do repeat CT scans. Did anybody take the time to look at how often the additional or repeat CT imaging done here affected management?
We attempted to look at that, how it did affect management. We looked at such as hospital course. We looked at did it affect an increase in mortality. We only had 3 mortalities in our database, so it was hard to determine or have an effect on mortality because we had such a low number. We did notice that patients with CT scans prior to transfer did have longer hospital courses and also longer ICU stays. But repeating the CAT scan had no incidence or no increase in hospital stay or length of ICU.
Not from a hospital stay, purely a management issue. Meaning, did we find something on the additional repeat imaging that actually said we need to go in a different direction for management?
No, we didn't look at that. No.
Can you go back to your data slide again about the number of, I think what was so the total number of children with an ISS of greater than 15 was 33 in the study. So yes, in fact, the vast majority of children with an ISS of greater than 15 got a CT scan, 27 of 33.
Yes.
Yes.
So it's majority. Sorry. Thank you, Dr. Mackey. I'll give you the $20 bill later.
We have time for one more question, Dr. Jackson.
And with you're looking at transfer time, what was your start point for determining transfer time into with the access to outside records you have? Could the longer time to transfer be accounted for their higher injury severity score and therefore higher time for the resuscitation and stabilization?
So the transfer time that we initially looked at was the time to first physician evaluation at the referring institution. We didn't take into account whether or not the patients were more severely injured. Did that significantly delay them in terms of their evaluation? But the previous study here, this study in pediatric emergency care, they specifically stated that transfer times were not associated with severely injured patients. They weren't associated with distances to the destination center. They're associated directly with the CT scanning that was done. And this was from Cincinnati Children's Hospital.
Thank you, Andy.
Thanks.
All right, up next is Megan Dermody on work that she did with Dr. O'Donnell in the vascular department.
Good morning, everybody. Thanks for this opportunity. I was moved up from a short presentation to a full length about 2 days ago, so I'll try to take up the bulk of the time. So I did this project last year with Dr. O'Donnell, and we used the help of Dr. Balk from the Department of Public Health. He did all of our statistics. He was a huge asset to this paper. So we were looking at complications of endovenous ablation of the great saphenous vein done in randomized controlled trials, and we did a meta-analysis of the data. So the background of this, superficial venous insufficiency is explained as a reflux time in the valves greater than 1 second. It's extremely common. The symptoms are generally tired, achy legs. They occur at the end of the day. Varicose veins is a common complication, and it can go on to create a lot of edema and then skin stretch and stasis changes, which can go on to ulceration. So the gold standard to fix this problem was ligation and stripping of the saphenous vein. It can be done both for the great and the lesser saphenous, as well as accessory branches. And it requires a groin cut down, which for the most part requires a trip, well, does require a trip to the operating room. Doesn't always require general anesthesia, but commonly was done that way. And then you take a stripper, you pass it down the vein, you pull it out, and you break all the branches in between. So that can cause a lot of damage with bleeding as well as potential nerve injury. So endovenous ablation is largely taken over for ligation and stripping. This is a procedure that many people are doing in the office now. You can give your patient a little Valium prior to the case. You lay them in a supine position, bend their knee a little bit, prep their leg out, and access the saphenous vein around the knee at the, with an ultrasound guidance. Once you get your catheter up to the saphenofemoral junction or saphenopopliteal junction if you're doing the lesser saphenous, you use, again, ultrasound guidance to inject some tumescent anesthesia around the vein. You want to create a nice bridge of a good 2 centimeters from the skin in order to prevent any burning to the dermis when you're heating up the vein, and then adequately get it away from the fascia as well. And many people have shown over several studies done that this is equally efficacious to ablate the vein and prevent the reflux that's causing their symptoms. So all of these randomized controlled trials look at the efficacy of how this compared to ligation and stripping, and that it completely solves the issues of the reflux. They did not focus on the complication rates of the procedure. So that was the impetus for our study. We looked at Medline and Cochrane databases as well as some individual journals over a 5-year time frame. The inclusion criteria was peer-reviewed, published randomized controlled trials that looked at either laser ablation or RFA ablation and ligation and stripping, and compared all of those cohorts. And this was specific to the great saphenous. We left out small saphenous in this project. We excluded any papers that ablated with foam sclerotherapy, as at the time that was not FDA approved, although it is now. Redo saphenous surgery we removed from the analysis, and if you had an endovenous procedure that was that had an addition of a high ligation, we removed that since that's not typically standard with the procedure. So this, all of these RCTs were combined to perform a meta-analysis. We used the short-term complications of each of the treatment arms to compare, and then performed odds ratio data to compare the differences between them. So there are about 665 citations. We pulled out the full-length English articles, and of those, only 17 randomized controlled trials met the criteria. And you can see how they break down here between all of the different procedures done. So the study quality, unfortunately, is not great. The intention to treat analysis was only done in a quarter of the RFA cohorts and half of the lasers. Only 25% were blinded. All trials do, however, have a balanced baseline characteristic, which is good, and they did all report their dropouts. 25% didn't specify their study protocol for how they examine their patients for complications, which definitely limits our ability to assess those. But they all did at least report the complication rates. And of course, reflux recurrence was their primary outcome measure. So there are quite a few patients randomized among all of these randomized controlled trials, and of those we had almost 600 in the RFA category, but only half of those used the newest version of the catheter, so that totaled 330 patients, and we only used those for our analysis. We had over 1,000 patients getting laser ablation. Those were variable wavelength catheters, which may or may not affect the ultimate complications, specifically relating to the amount of heat capacitance and therefore heat-induced injuries. Less than 1,000, but 975 patients there had ligation and stripping. Vast majority of these patients are female, which goes along with the disease process. The majority of them have a fairly minimal clinical class, meaning varicose veins or edema, but most of them do not have ulcerative disease in these trials. The vast majority did have concomitant stab phlebectomies at the time of the ablation, which could theoretically increase their wound infection rates. And there was very variable chemoprophylaxis provided for DVT, which continues to be the case. There's no standardization for that. And then ultrasound was done within about 2 weeks for all of these patients, but they don't specifically look at the entire leg for DVT. They're primarily just looking to see if the great saphenous is recanalized or not. So this is the main data here. You can see on the top line that the DVT and PE rates, which we combined but then subsequently separated and looked at individually for another paper subsequently, they're not statistically significantly different among any of the types of procedures. The infection rates, as you would probably expect, are highest in the ligation and stripping group related to the small incision you're making in the groin. So that proved to be significant against laser. It trends towards significance against RFA, and I think if we had more patients in the RFA category, that probably would have been significantly different. The paresthesia rate, mostly I can say that laser ablation seems to have the lowest rate. It is significantly lower than RFA even, and there are various reasons for that, which I could get into if we had more time, but I'll keep going anyway. So superficial venous thrombosis is not at all surprising to not be present in ligation stripping group since you're taking that vein out. But you can tell your patients if you're performing these procedures, there's about a 5.5% chance of that occurring following the ablation. Bruising and hematomas are extremely hard to understand in the literature since it's a very subjective measure and you don't really know what people are considering significant bruising. So I'll just mention that with a grain of salt. These skin burns are not significantly different among the ablation techniques. So the conclusion is that ligation and stripping has a higher wound infection rate compared to the RFA and the laser ablation techniques. Ligation and stripping has a lower thrombophlebitis rate, again, not at all surprising there. But thankfully the thrombophlebitis rates are very low, even with the RFA and the laser ablation. Laser ablation seems to have a lower paresthesia rate, potentially because there's less heat capacitance going through the vein compared to RFA. And then, of course, these complications are pretty benign. They're self-limited. Paresthesias can certainly be permanent, but they're not life-limiting or lifestyle limiting. And of course, the meta-analysis has plenty of limitations. The quality of the data is not great. It's highly underpowered, and there's a lot of variability in the follow-up. Thank you very much.
Questions for Megan? Dr. Roy?
Megan, that was a nice talk. Can I just ask, when these devices come out, just kind of a general question, not specific to your data.
Mm-hmm.
When these devices come out, radiofrequency ablators for veins, laser ablators, isn't there now some sort of FDA post-approval
Database or
because right now they launch these out there, and every vascular surgeon, every community hospital wants to drag in some women for treatment.
More than just vascular surgeons. Yes, everybody's doing it. Yeah.
But couldn't you improve the quality of the data just by enhancing the FDA post-approval process? Or you can use this, great. Go for it, great. But you got to supply the data.
Right. I'm not clear. I don't know whether or not that, because I'm familiar with having to report your data to them, but I don't know if that's publicly available data. So yeah, it would make perfect sense to have that reported data scrutinized for, for the reported rates of complications that are coming back. The problem is, so theoretically, I guess you could take every billable case in America to know how many procedures are being done and then look at how many complications are being reported and try to come up with the with the rate of complications based on that. Seems feasible. I don't know if it's public data, though. I don't think it is.
Nicely presented, Megan.
Thanks.
For a lot of work. What did you learn from all this that will influence how you practice?
Great question. I basically feel like I just have some hard numbers I can tell patients when I'm consenting them for the procedure. I think if you tell your patient that there's a very low risk, these are all of the problems that could occur. They're relatively low risk, and most of them are gone within a 3-month time frame. Just I guess ease their anxiety about undergoing the procedure. That would be good. I think you still have to give your patients when you're telling them other alternatives, the ligation and stripping alternative is still there, but you can at least tell them that compared to the more minimally invasive technique that your newer technique seems to be less complicated or whatever.
Is there any longer-term data on treatment failures for the relative modalities? So patients who come back with significant reflux, either in the ligation stripping, that would be in an missed accessory branch, or in the RFA, it might be recanalization.
Yeah, there's a lot of data on recanalization, recurrent disease. We're actually trying to put together a paper on recurrent varicose veins after ablation techniques. So I haven't scrutinized that data yet, but yes, there is a lot of data. It's just a matter of putting it together.
I guess the real question is going to be, is there any role for ligation and stripping going
Right.
forward?
That's a very good question. Doesn't seem to be the case.
Thanks, buddy.
Thanks.
So we're going to go a little out of order only because Christoph is running a little bit late. So Nicole's actually up next. And she's going to be presenting work that she did with Dr. Nazway.
Good morning. Thank you for the opportunity to present our work. So as we've heard in this forum before, hyperglycemia, hypoglycemia, and glycemic variability are all associated with increased morbidity and mortality in the critically ill. So this is a tracing from a standard ICU patient with intermittent blood glucose draws. The blood glucose concentration is plotted on the y-axis versus time. This is the same patient's plot from a continuous glucose monitor. You can see that at this part of the graph, the plot fits nicely to what you would expect based on the independent draws done intermittently at varying time points. But you can see here that with only doing intermittent blood glucose draws, we've missed an episode of hyperglycemia as well as glycemic variability. So continuous glucose monitoring has the potential to improve all three metrics of glycemic control in identifying missed episodes of hyperglycemia and hypoglycemia, and also missed glycemic variability that is prone to happen when you're doing intermittent blood glucose draws. So the ideal CGM would be rapid, accurate, free of interference, particularly from vasopressors or sepsis or other conditions that ICU patients are prone to have. Inert, robust, meaning that it can adapt to a rapidly changing ICU setting, minimally to non-invasive, and cost-effective. There are many sites in which people are working on developing continuous glucose monitors, from most invasive, which would be intravascular, to subcutaneous, to transcutaneous or transdermal. The system that we studied is called the Symphony CGM system, and it includes a prelude skin abrader, which is seen here, which is used to abrade the skin to obtain access to the interstitial fluid. The monitor is then placed and then wirelessly transmits the blood glucose level to a monitor that can be placed at the patient's bedside. There are many metrics that people are using to determine the accuracy of different CGM systems. The first is the Clark air grid analysis. This plots the device values versus the reference control and is divided into 5 separate areas, which I will discuss in more detail later on. The second is the mean absolute relative difference. This is the difference between, again, the device and the reference blood glucose measurements. It's represented as a percentage, and a lower MARD corresponds with a more accurate device. The FDA has said that 15% MARD is what is the highest MARD that's supposed to be acceptable for use in an ICU. But interestingly, the current Tufts glucometers, which is called the AccuCheck Inform, has a MARD of 16.5%. And this is typical in ICUs throughout the country. The handheld glucometers were actually developed for use by diabetics in their home, but because we had no better alternative, have been moved into the ICU setting, and as you can see, have many improvements that could be made in accuracy. So the objective of our study was to determine the accuracy and the safety of the Symphony CGM system in critically ill cardiac surgery patients. We evaluated 15 adult cardiac surgery patients at Tufts Medical Center. The Prelude skin prep device was used to prepare the skin, and the sensor was applied at 2 different test sites. Venous reference blood samples were then drawn at 30 to 60 minute intervals, and they were run on the YSI 2300, which is the laboratory standard analysis for blood glucose levels. The skin at the test sites was then inspected, and the Clark air grid analysis was plotted, and the MARD was calculated. So table 1 represents our patient demographics. You can see that we had 4 females and 11 males in our study. The age ranged from 39 to 87. The BMI of the patients was anywhere from 16 to 45. 1 patient had type 1 diabetes and 2 patients had type 2 diabetes. The values for the blood glucose measurements range from 73 to 251, so you can see that we did not have any instances of hypoglycemia in our study. The MARD was 12.3%, and there were no unanticipated adverse events. So figure 1 is the Clark air grid analysis. You can see on the y-axis the blood glucose from our sensor, which is plotted next to the reference blood glucose from the YSI analyzer. The Clark air grid, like I said, is divided into 5 zones. So zone A is what they call clinically accurate, which is that the predicted blood glucose is within 20% of the reference range. Zone B are values that are outside of the 20% cutoff, but that a benign treatment is given. So you can see that here in the orange. Zone C is patients that actually are in the euglycemic range on the reference blood glucose, but were treated as either hypoglycemic or hyperglycemic based upon values from the predicted blood glucose. And then zones D and E deal with the hypoglycemic and hyperglycemic spectrum. So zone D, you can see here, the reference range is actually hypoglycemic, but the predicted blood glucose, or the blood glucose measured by the device, is within the euglycemic range. So we're missing either hypoglycemia or hyperglycemia in treating these patients as euglycemic. And then zone E is the most dangerous. It's patients in which they are either hypoglycemic or hyperglycemic, but are treated as the opposite. So somebody who's actually hypoglycemic is getting more insulin because they're thought to be hyperglycemic. So you can see that our data, 81.7% is within zone A, which is within 20% of the laboratory standard. And the rest of the data, the remaining 18.3%, is within zone B, meaning that a benign treatment was given if anything was outside of the 20%. So basically, the treatment based on the predicted blood glucose is the same that would be given based upon if we had been using the laboratory standard at the bedside. So the Symphony CGM was safe and relatively accurate in continuously monitoring blood glucose in critically ill patients after cardiac surgery. There are some limitations of the current Symphony device, which includes lag time, which is around 10 minutes. It takes 10 minutes to get the device up and running from the time that the skin is abraded. Calibration frequency, which at this point is every 4 hours. And sensor life. Both the dermabrasion site and the sensor have to be changed after 24 hours. In conclusion, Symphony CGM can be used in the future to drive the intensive insulin treatment of critically ill patients. We would like to do some further study, which would include hopefully working on a device with a shorter lag time and less frequent calibrations. And then studying a broader ICU population, including patients that are not cardiac surgery patients, septic patients, patients with hypovolemic shock, and patients who have blood glucose levels within the hypoglycemic range. I would like to acknowledge my research mentor, Dr. Nazarway, for his help on this project and all the other projects that we've worked on. And then Wayne Menzie and Gail Congable, who taught me literally everything I know about continuous glucose monitoring. Thank you.
Questions for Nicole?
I know this isn't part of this particular research question, but is there any clinical significance in terms of having this continuous monitoring and missing those small peaks or valleys in the more traditional manner in terms of management? This is obviously going to be an expensive technology to apply. The principles of tight glycemic control in the ICU patients is a subject of debate. And so I just wonder, in that graph that you showed at the beginning, where there was that brief period of hyperglycemia that was missed, does measuring that one blip or that variability and treating that actually change outcomes there?
Yes, there is. There's actually a lot of data that glycemic variability in and of itself leads to increased mortality in critically ill patients. And there was another study done by McKenzie that showed that glycemic variability is synergistic with both hypoglycemia and hyperglycemia. So when they have more than one derangement, their mortality is even higher. So I think that all three derangements could be affected by the continuous glucose monitor. And I think the ideal direction going forward would be that there is a continuous glucose monitor that's feeding directly into a software system such as the glucose stabilizer that we use here at Tufts, and then that's directly adjusting the insulin drip so that we can keep patients within a very tight range without having problems with hypoglycemia.
Is there any, you mentioned that you were monitoring the skin abrasion sites, were there any complications or issues?
No. Each patient had 2 sites. There were 30 sites, and there were no complications. Yes.
Do you think the relative paucity of data points of the blood sugars over 200 affects your assessment of the device performance?
Yes, and like I said, we didn't test it in the hypoglycemic range. This was just a pilot study, so that's why we only had 15 patients, and we were just using the standard of care in the CTU at the time, so they were keeping blood sugars anywhere from 100 to 180 milligrams per deciliter. And so the future study is certainly needed, and it's actually being performed now. There's a multi-center study going on with more sites and more patients that will hopefully iron out some of these difficulties that we had with the pilot.
Do you have any data, or did you analyze, I realize you have only 200 endpoints, any populations in which the accuracy will be higher and any population in which the accuracy will be lower?
There's been a lot of speculation about the effect of vasopressors on different continuous glucose monitoring systems and with mixed results. So I think that that's something that needs to be ironed out with our particular system. Because these were relatively stable post-op patients. I think that the results would be different if we had some of the patients that we currently have in the surgical ICU. Other studies, particularly in intravascular devices, have shown that there really is no difference in accuracy when patients are on vasopressors. But I think that that's something that needs to be ironed out for this particular system.
Thank you, Nicole. And up next is Maria Tra with work that she did with Dr. Nazway as well.
Good morning, and thank you for inviting me to present this work, also done with Dr. Nazway, where done in our own ICU, where we have found that horizontal infection control strategy can decrease our MRSA infection rate and eliminate bacteremia in a surgical ICU. So MRSA is a common and lethal multi-drug resistant pathogen, as we all know, that is widespread in the world, in the community, in ICUs, and in hospitals as a whole. It's a particularly virulent pathogen. It's got 7 genes that encode for resistant to 7 different classes of antibiotics and up to 70 other different virulence factors, which make it a particularly morbid pathogen. So what general strategies are there to deal with multi-drug resistant or any pathogen? So more and more in the infection disease literature, we're seeing the discussion of vertical versus horizontal infection control measures. Vertical control measures identify using a kind of a search and destroy or active surveillance strategy, screen patients as they come in for a particular pathogen, and then treat and decontaminate those patients. Whereas a horizontal infection control strategy does not initially screen for a pathogen, but instead treats with global infection control measures all patients without knowing whether or not they're colonized or have an infection. And then only if they manifest with a clinically significant infection do you then treat that patient and isolate them. And there's been debate in the literature about which one of these strategies is better. Especially with the vertical control, vertical strategy, some research has shown that they have reduced patient contact, significantly reduced provider-to-patient contact hours, which has led to delays in diagnosis, also worsened nursing care with increased falls, increased electrolyte derangements, and increased sacrodecubitus ulcers, hence the interest in a horizontal strategy. So our study design, we looked at nearly 6,700 patients in our ICUs using our ICU databases, and this was done retrospectively as an observational study. And we essentially looked at the effect of, over time, adding in cumulative horizontal infection control measures on the overall rate of MRSA incident invasive infections and MRSA bacteremias in particular. So most importantly, hand hygiene. That was a focus early on. And at this particular institution, we instituted a target of 90% compliance with pre- and post-contact hand hygiene. And as you can see in the beginning of the graph, we were mostly above 90%. And then as commonly happens, there was some protocol fatigue. People stopped participating as much and needed a re-education campaign and another hand hygiene campaign, which then got our values up again over our 90% rate to where they're currently sitting above 90%. Which is actually an excellent number. And in the literature, it's found that the threshold actually for making a significant change to patient outcomes is being over 70%. After hand hygiene, we looked into chlorhexidine interventions. So once to 3 times daily patient bathing with chlorhexidine, and then chlorhexidine oral care protocols. In addition, chlorhexidine is an important part of our central line protocol, and this is one section out of our daily goal sheets, which shows a quality measure, and one of which is central venous catheter. And so we look every day to see whether we absolutely need that catheter, and we try to get it out as soon as possible. And we make a standard that for non-coded catheters, we take them out by day 10, and for coded catheters by day 15. So this is an example of one of our coded lines, and we use chlorhexidine pre to prep the site. We use full patient draping, and then we use a chlorhexidine biogel patch for central line dressing. And very importantly, those dressings need to be maintained after by the nursing staff in a sterile way after the line has been placed. So this is a graph showing our overall results. So you can see that the infection incidence per 1,000 patient days was reduced from 2.66 down to, or 2.6 to 0.7 in 2012. So that's approximately a 22% decrease every year, which is a statistically significant decrease with time as we added in more of these horizontal infection control measures, which you can see down below. We then ran some local regression analysis and found that there was a change point in 2008, which is right here, where you see that the curve has become much steeper. And this is coincident with the implementation of the central line associated bloodstream infection protocol, which is a highly protocolized, as I described. And this seems to be particularly important to reducing our overall MRSA infection rates, in particular with regard to bacteremias. And then we used an ARIMA model which is an autoregressive integrated moving average model, which interestingly can predict where we think our MRSA infection incidence will go in the future. And as you can see, it predicts a further downtrending. And overall, all of these numbers are actually much lower than in most of the documented literature in other ICUs, but particularly the predictions are much lower than in other ICUs. And this is my favorite slide. This shows our MRSA bacteremias, which has not been shown in any other ICU in the literature. But in our last 5 years of the study, in nearly 4,500 patients, we had 0 MRSA bacteremias. So coming back to vertical versus horizontal infection prevention measures, we've shown, at least in a retrospective review, and this is certainly one of the limitations of this study, that horizontal infection prevention measures can reduce our MRSA bacteremia rates and overall MRSA infection incidence rates quite significantly. But again, we didn't have, unfortunately, any internal controls to see whether the MRSA prevalence for patients coming in was changing over time, number one. Number two, we didn't have internal control comparing vertical versus horizontal strategy. So one of the things that we might like to do in the future is, although we don't want to, we'd rather not do a vertical control because we're seeing that our horizontal controls are working quite well. But one of the things we can do is look at a cost analysis between the two systems. Vertical control measures are associated with significant costs in terms of screening, swabbing, and isolating. And then, of course, all our horizontal measures also have a cost. So it'd be interesting to see whether the horizontal measures actually overall are lower cost per MRSA infection avoided. So in summary, this multifaceted horizontal infection strategy can reduce our MRSA infection incidence without the need for active surveillance. So I would suggest that hospitals first look into just establishing good general infection control strategies before moving to screen for and isolate individual pathogens. And overall, 3 key points: hand hygiene targeting. If you target a higher than the national standard, so if you target 90%, in our study, we had 92% of months we were over the 70% standard, and you really need to keep an eye out for protocol fatigue and do refresher courses. Number 2, the central line-associated bloodstream infection protocols are extremely important and seem to be the most significant in terms of reducing MRSA bacteremias. And finally, we need to really value and educate our nurses because the nursing interventions are really paramount in infection control. And I'd like to thank Dr. Nazwe for his mentorship. And Dr. Nubari, who gave our keynote, was actually the statistician on the project. So thank you. I'll take questions.
How did you account for patients transferred from the outside with pre-existing MRSA infections?
Right. So our definition of MRSA incident infections was new infections occurring in the ICU that were documented within 24 hours of arrival. So if they already had an MRSA infection coming in, then they were excluded. Yeah.
And that's based on standard practice by our infection prevention committee in accordance with the definitions by the Centers for Disease Control.
Okay.
Andy.
Sorry to ask a question, Maria. Did you notice that any intervention was better or worse than another? Like when you added the horizontal interventions from 2008 to 2012?
Yeah, so that's what we were trying to get at with this analysis. Unfortunately, one of the limitations is because they were cumulative, we couldn't really distinguish cause and effect of one particular intervention. However, here in this local regression analysis, you see in 2008 the slope is much steeper for that part of the curve, and the intervention in that year was the central line bloodstream infection protocol. So we conclude that that's probably a particularly important measure to implement. Dr. Rohr.
Yeah, Maria, that's a nice talk. I'm intrigued by the whole interventional epidemiology aspect of this and your nice description of protocol fatigue in that role. In general, when it comes to vertical versus horizontal approaches to these things, which is easy, which is the better for avoiding protocol fatigue? In other words, if you're doing some standardized thing all the time for every single patient, is protocol fatigue less likely to happen than if you're trying to pick up spot? You can make all sorts of analogies to like picking up terrorists who are going to climb on your plane and stuff like that. It's an interesting little corner of this.
That's a good question. I have not actually seen anything in the literature comparing protocol fatigue in these two different overall ways of going about infection control. But what is very well documented, which is, I guess, kind of like a protocol fatigue, is that in the vertical, so search and destroy strategies, what you do see is that you get provider fatigue, and when people are isolated, even if they're not actively infected and they're just colonized, providers don't go into the rooms as often, don't spend as much time with the patient, don't uncover the patient and examine them as well, and that really does lead to reduced patient care and reduced patient outcomes. So,
supplementing that, we actually have real experience with that, Rick. In 2000 and 2004, the surgical ICU, maybe even frankly a little bit ahead of the curve, was doing active surveillance. We were surveilling everyone who came in the ICU, and every 7 days thereafter, with nasal swabs for MRSA and perirectal swabs for DRE. You remember, as a transplant surgeon, you point to DRE. So from 2000 to 2004, every admission was being actively surveilled, just like they do in Europe and the VA Medical Center, and in 9 states by law here in the United States. And when we talk about fatigue, we discovered, the nurse manager and the physician director of the unit, that in 2004, the nurses were slowly stopping the active surveillance because they couldn't stand it anymore. So when you talk about fatigue, the reason we got to where we are is that our nursing staff refused to do it anymore. And we couldn't prove that it was making a difference in patient outcomes, so we discontinued doing it.
and I would have loved, we have some of the data from that time period where we were doing active surveillance, but unfortunately it wasn't as, the records were not as complete as the subsequent numbers. Otherwise I would have shown them, because that would have, of course, been nice to use that as our control. Yeah.
So there's a nice corollary to a lot of other things that we do. I think Stan's point is well taken, that it's actually probably, I'm going to guess, more difficult to do the kind of intermittent target approach than to just do the same thing
Blanket.
every time.
Mm-hmm.
Which gets to like, why do we have this ticket to safety business? Why do we have to check this off every single time? Well, it's true, many of the times, maybe most of the time, it doesn't really contribute that much. But if you try to do it the other way, just like recheck the physical exam on just the patients who need it, that sort of thing, it's way worse. The protocolized way.
I'm going to turn the floor over again to Maria. She's got one more presentation. This one's the short one, okay?
All right, so I'm back already. This time I'd like to present it's a bit of a conglomeration of work that started off between myself and Drs. Orkin and Popwich when they were still here, and then was significantly enhanced by the addition of Nicole Sauer to the project, and then most recently by a collaborator in the University of Cambridge. So here we were looking at the effect of or looking at CT scans in Crohn's disease and whether there were any particular indicators that made CT scans more or less useful in Crohn's. And what I will go on to show is that chronic narcotic use is a significant predictor of increased CT scans. But the explanation for that I will tell you in a moment. So this was all started off as a retrospective observational study in 86 patients over a 4-year period, and we looked at several variables. We looked at hospital or ED admits, hospital admits, trips to the operating room, number of CT scans, and narcotic use and pain clinic attendance. What we found was that patients on chronic narcotics really had significantly more CT scans per patient, which is not surprising. So you can see here that the mean CT scan was 4.1 for a chronic narcotic user and 1.4 for a non-chronic narcotic user. This also translated into a significantly more ED visits for chronic narcotic users, as well as significantly more CT scans. All of them in our population had a CT scan, but did not translate into a statistically significant difference in OR visits. So from that initial research, we concluded that in patients with chronic narcotic use, perhaps we should use a different threshold for ordering CT scans because it's contributing to a significant burden of radiation in those patients and what we thought would be excess scanning. But I was thinking about the data collection method that we used for those patients, and the fact that I wasn't really very happy with how with our Excel tool the quality of the data that we collected. So I thought a little bit about the challenges of data collection and what a really good system would be, what key features it would need to have. So number one, it needs to be able to have a volume of data input, and that needs to be automated so that different providers can put in information and we can pull all that information together. It needs to have it needs to capture complexity of information, but still maintain the granularity of the information so we can pull quality data from it. And most importantly, it really needs to preserve temporal relationships between events. So for example, a patient interaction in a CT or in the OR needs to be able to be mapped onto an admission or an outpatient visit and then onto an overall disease pathway. And if you have a system that captures all of these things, then you can really enhance research, clinical care, and service planning. And so I started designing, again with my collaborator in England, a series of data collection forms, mostly around assessment, interventions, and outcomes common in Crohn's patients, and mapping them to elective and non-elective care in an admitted setting or in an outpatient setting. And then I ran the numbers again, so using this as a feasibility trial. So again, running the numbers again, we saw that narcotic users, even though they make up less than 20% of our total Crohn's population, accounted for more than 33% of the total CT utilization. But what was surprising was, although in our first series of studies, we thought that actually the CT scans are low yield, when you look at the actual findings, 80% of those patients with who are on chronic narcotics actually do have positive findings. And that's more than the non-narcotic users. And if you look at how that breakdown happens, they have more bowel wall thickening, which suggests more chronic active inflammation. They have more incidences of bowel obstruction, small and large. They have more incidences of abscesses, and they have more incidences of fistulae. Ooh. So in short, chronic narcotic users do get more CT scans. Both our methods of looking at that research agree on that. But why? Initially, we thought we were just overscanning them because they were complaining of pain. But do they actually have a higher burden of disease? So my overall conclusion here, aside from just looking at the data and looking at Crohn's, is incomplete data collection can lead to some incomplete results and incorrect conclusions. And that's why I aim to make this one of my main goals for next year, is to develop this robust Crohn's registry so we can get more clinical outcomes research. Thanks.
So we'll try and sneak Christoph in a little bit later this morning. So I think a round of applause for everyone who presented is well warranted and earned. And I'll turn it back over to Dr. Rabinovich.
Okay, we're now going to start with the research market. We'll do it by division in alphabetical order, and the presenters will be the division chiefs or their designees if they're not here. The first one, it will be Sunny.
Good morning. So I'm going to just talk briefly about ongoing projects that we have in the bariatric and MIS surgery service. Dr. Kim and I are involved on several projects. One that I don't have a slide on, but I am working on, is something called V-Block, which is a multi-center randomized trial. Some of you have scrubbed me on these cases. Basically, we're taking electrodes and we are placing them around the vagus nerve, both branches, and then those leads are attached to a neuroregulator where for 12 hours it intermittently blocks the vagus nerve. And initially it was randomized, double-blinded study. Now it has been unblinded. And we looked at weight loss, and I actually went to the FDA on Monday to present this data to them to hopefully get it approved, and it did get approved for the initial review to go to the FDA, so that's wonderful news for the company. And we've seen basically the excess body weight loss, and this is how we term success for any sort of weight loss procedure. For this one, it's 25% excess body weight loss at 6 months, and then about 23% at 12 months. So the data looks really good. Resident involvement in this project is minimal at this time, but as we move forward, it will definitely open up to write more papers. So if anybody's interested, please find me offline. The one that I really want to talk about is sleeve gastrectomies. Now, nationwide, it's become the #1 procedure that we're doing for weight loss. For those that are not familiar with this procedure, it's basically taking the stomach and making it into the shape of a banana and removing about 85% of the stomach. There has been a lot of controversy in the literature in terms of indications, patients who should not get it. And one of them, which is still very controversial, is gastroesophageal reflux disease. So by just how we make the sleeve and the anatomy of the stomach, we're basically making the stomach into a very high pressure zone. And so there's a lot of research and data out there in terms of heartburn. So, there are some centers that if patients have, really bad heartburn that's not being managed on medications, these patients are not being offered a sleeve gastrectomy and are being offered a bypass instead. Another thing that we're looking at is something called Barrett's esophagus. So just by having Barrett's esophagus, if it ever turns into full-blown esophageal cancer, then these patients, if they do need a total esophagectomy, obviously if we've basically taken 85% of the stomach out, we can't get the stomach for reconstruction. So we are looking at this data. I just pulled the data. Our first sleeve was done in 2008. Since then, we've done about 450 sleeves. So we are looking at, I am making a database in terms of looking at, patients who had preoperative heartburn, post-operative heartburn, if it did resolve, if it didn't resolve. We do have a few patients that everybody gets an endoscopy before the sleeve to document any Barrett's esophagus. We do have a couple of people that did have mild dysplasia, not full-blown Barrett's esophagus, and we are doing, routine endoscopies. But to look at that data, so they get repeat endoscopies every year, every 2 years, to see if it does make it worse by, creating a sleeve gastrectomy. So we're, we can really use some help in terms of pulling the data on that. Dr. Kim is also looking at it's a study it's combined with infectious disease, and basically we're looking at patients after a gastric bypass. They are giving these patients probiotics before surgery, about 2 weeks before it. They're asking for a fecal sample, and they're looking at the flora of their stool. Then they're giving them probiotics 2 weeks before surgery, and then rechecking their stool, and they're looking at, I guess, just drugs and probiotics and how it can affect the gut flora, especially after gastric bypass. So those are the two main things that we are working on currently. Other ideas, while I make this database, there's so much more information that we can pull, which I am also pulling, is weight loss. So, there's some studies that are looking at, weight loss, comparing the sleeve versus the bypass. some studies show bypass maybe a marginally more. The last study looked like sleeve was, just as much as a bypass, if not more. Another thing that I'm personally interested in is just quality of life. Patients who've had the sleeve gastrectomy, I have to feel and believe that they have a better quality of life because they don't get the dumping syndrome. They're not coming back with obstructions. They're not having these severe vitamin deficiencies that we see with the bypass. They're not getting iron infusions. And again, the latest study doesn't really show a difference. So these are just things that we're questioning and still need answers to. Thank you.
Well, next in line is the cardiothoracic division. Is Doc here? He was here. He gave his slides. Okay, we'll give him the opportunity hopefully later. Colorectal. Dr. Yu.
Hi, everybody. Research is a really important part of what we do in the Division of Colon and Rectal Surgery, and we think it's really important for residents, for your training, and for the medical students as well. And for people that are working with us, we hope to provide great mentorship, really interesting projects, and opportunities to present your work at national meetings and to publish your work in peer-reviewed journals. Those are our expectations when we do our research. Let's see here. So Dr. Melnichuk, she's actually about to start her master's in clinical and translational research, and she has initiated a number of projects related to health services research and global health, which you can see here listed. These are great opportunities for motivated residents or medical students still in the course of your residency. You could be involved in some of these projects. I have a basic science lab. These are opportunities more for, I think, junior residents that are considering taking a year or two off to work in the lab. I study tumor microenvironments, stromal epithelial interactions. They're both cell culture work and animal models in the context of colon cancer. When I was a surgery resident, I had no intention of doing basic science research. I sort of did it as a default, and I always thought it was really boring, like I'm sure a lot of you do. And then I had a phenomenal experience, and here I am with my own lab. So if you're considering it, please come and talk to me. There's actually some really good, exciting work we're doing. And then lastly, just some QI projects. Dr. Cooper mentioned this last week. We're still sort of developing our division, and we need a lot of help developing order sets, enhanced recovery pathways. These are simple things that we can do that will actually really improve the quality of care we provide. Thank you.
Roger?
Duck's back, so Roger had to go.
Duck. Where's Duck? Okay, come on. Let's.
You gotta get back.
Yeah, I know. Yeah, he'll just stay back.
Good morning. Thank you, Dr. Mackey and the rest of the department for inviting us to participate, and also to Reuven for organizing all of this. I try to get all this out of the way. I'll try to be brief, since I just learned this morning that I only had 2 minutes instead of the 10 I was told earlier. So these are my disclosures. See, Reuven had mentioned earlier the issue of funding for research, and I think it's very pertinent because one of the key things in terms of obtaining funding for research is asking the relevant questions and getting the pertinent answers. Fortunately, in cardiac surgery, with the prevalence of heart failure and the growing epidemic of patients with advanced heart failure, the issue of relevance and pertinence isn't so important in terms of obtaining the sort of critical mass for research funding. As you may have already heard in the previous talks in our Grand Round series, the the development of mechanical circulatory support, and in particular ventricular assist devices, has changed the field for advanced heart failure dramatically over the past 5 to 10 years. These are examples of some of the surgically implanted devices that have come out in the previous years, with the HeartMate 2 and the Heartware HVAD as two of the most common devices that we are currently using clinically. These are also some examples of percutaneously implanted devices that are out there on the market currently, which we have participated in research with. The question that remains, however, with advanced heart failure is, when is the proper timing for intervention with these devices? This is a representation of the natural history of heart failure, with advancing heart failure from class 1 to class 4. Patients are being hospitalized more frequently, and the mortality rates are increasing dramatically. The question is, what is the proper window of opportunity in terms of applying these devices, whether or not we can save these patients and through productivity, when it becomes futile to even try anything, and are there devices that can actually pull these patients back from futility to survivable states? Furthermore, in the next few years, we're going to see further advances with these two new devices coming out in the next coming years. One of our research aims at Tufts Medical Center in the Surgical Research Lab is to answer the question of not only is there hemodynamic advantages to these devices, but can we induce myocardial salvage ventricular recovery, and as well develop further technologies where we can preserve the right ventricular function, because right now the main devices that are out there on market are mainly aimed at left ventricular support. This is one of the newest devices that's about to be first in man in a couple years from now. We were fortunate to partner up with the Heartware company in terms of developing preclinical studies with this. The bottom picture is a acute heart failure model that we created here at Tufts, where the LAD or other coronary vessels are ligated, creating an acute heart failure model in either porcine or bovine live animals, and then implanting this small ventricular assist device for left-sided support as well as right-sided support. This is one of the abstracts that we presented a couple years ago at the International Society for Heart-Lung Society. Just to go over it briefly, we created a infarct in this porcine heart. Pig went into heart failure. We implanted the left ventricular assist device. Using a intraventricular conductance catheter, we measured the hemodynamics of this particular pig, and you can see in this the results of this study, with increasing support from the ventricular assist device, we were able to decrease the workload and pulsatility of the heart, and essentially eliminating all workload for this failed porcine heart model. This video is probably not going to play, but the other nice part about this new device is that it has programmability to automatically decrease its support, allowing the native heart to exercise, with the potential of using these devices that bridge to recovery. Another model that we used is in terms of percutaneous device, seeing whether or not the impeller device, tandem heart, or ECMO has superiority over one or the other. In a similar model that we created with the infarct model, we compared the three and has clearly shown that ECMO, although increasingly being used, is actually not as effective in terms of unloading a heart in acute myocardial infarction, playing probably a large role in the future in terms of what strategy we would use for patients in acute myocardial cardiogenic shock. So this is a sample of some of the abstracts that we've published, we presented recently, and the publications in the past year. We've completed our first series of studies where we garnered about $500,000 of research funding. We are now looking at our SRA 2 and 3 with already $2 million signed and contracted, and another $1.5 million in negotiations at this point. Thank you for your time. Sorry I had to rush through all that, but that was...
Is Dr. Graham here? Plastics, Dr. Driscoll.
Do we have any slides, I hope? Let's see. Okay. Okay. Thanks very much for the opportunity. This is a great opportunity. The plastics division is just a couple of us. Dr. Sadowski, he's got an MBA. He's interested in trying to streamline some of the processes that occur and trying to make the business side of medicine work a little bit better. So if you're interested in something like that, she's going to try to start up some programs on that. I've got some personal interests in pediatric burn reconstruction. I work at Shriners and have for the last 16 years. With that, I've also been involved with some global health initiatives and pediatric burn management in several different countries, mostly Ukraine, and you've already seen my presentation in that. And then I'm interested in some of the technological innovations in plastic surgery, and while I currently am not financially involved with the medical industrial complex, I hope to be one day. So there's a lot of interesting things out there that might be a good idea for an observational study. And then Tufts Medical Center also presents specific opportunities. This last 2013-14, we've had 11 presentations, 7 publications, and I did 3 international missions. Pediatric burns, I do a lot of work with tissue expanders. It's mostly on the reconstructive side of things. I've done some work with Justin Fernandez on med-poor ear reconstruction. That'll be published soon. I've been doing a lot of work with Indocine and Green, that's the SPY Elite, for evaluation of flaps. This can also be used in other areas here at Tufts because we have the machine here. Some microtia work, tracheocutaneous fistula after burns would be a good case report. Prep use as a skin graft. And then I've been working on how to reconstruct the nose when the forehead's severely burned. Global health initiatives, that's most of the publications that have occurred recently. Been working with telemedicine, a burn outreach program in Lviv, Ukraine, which is spreading across the country to Kiev. I will not be going there this year. Got the kibosh on the hall pass from the wife. But soon, next year, 2015, I will be going. And in the past, we have taken anesthesiologists and plastic surgery residents. Working on a burn database to try to help lead to things such as a prevention program. And that has also indicated that there are way too many blood transfusions in Ukraine right now, and we can try to decrease the need for that. So we've got a lot of global health and public health initiatives. And finally, some technical innovations. I like using the SPY machine, trying to find new innovations for that. Been using the dermaclose device, and I think I'm probably one of only 2 surgeons in Boston right now doing a lot of work with oncoplastic breast reconstruction. That's reconstruction of the breast after it's deformed from lumpectomy and perhaps radiation, or doing breast reductions after lumpectomies. Tufts Medical Center has offered opportunities since they gave me the moniker chief. People come up to me and ask me to help them out with being an expert for systematic reviews. I was involved with a TEI study on acellular dermal matrix in the pig study here at Tufts. We have a large volume of massive weight loss patients that are good observational or review patients. We have quite a busy breast cancer center. And with the Indocine and Green here, for instance, Mass General still hasn't bought this machine. It's been out for 5 years, and it's very innovative. And we can leapfrog beyond what other people are doing with things like immediate breast reconstruction with implants. And now being in Boston, we can collaborate with other centers here in Massachusetts, in the Boston area, such as Mass General, Brigham, BI, for things like the marathon bombing problem, and we've tried to do some collaborative research on that. So there are a lot of opportunities. If you have an interest in something in specific related to plastic surgery, just keep nagging me. My wife tells me that works, and I'm happy to try to come up with a project for you. Thanks very much.
Stan? Sorry.
That's right. Do you have...
Yeah. Put them down here. I have to minimize this. Minimize. And then.
So, this will be my first time seeing the slides too, so hopefully they're fairly self-explanatory. And we'll keep our fingers crossed. Yep.
Okay. So it looks like we'll go without slides. The basically with pediatric surgery, we've had a fair amount of research through Walt Schwalls looking at pediatric trauma, which has led to presentations such as Andrew's earlier at international meetings. And the extent of pediatric trauma and the research also goes into ICU care, and I believe Dr. Schwalls has several projects that are either in process or no, for whatever reason that rehab doesn't run. I think that's yours.
Okay.
Other projects that we have going are in progress, and ones that I'm working on and could certainly use help with. We have some with our residents already. Andrew and I are going to be relooking at some of our data, looking at percutaneous endoscopic G-tube placements, and looking at historical controls, using the laparoscope as an assistant device, and then also looking at how this compares with the earlier methods with respect to granulation tissue and other complications. Have an innovative model, as you know, for the folks who've gone through Metro West, where we partner very closely with a pediatric hospitalist, which is allowing us to expand surgical care to non-academic sites, and taking what we can do to the community hospitals where patients would normally be coming in to see us, and shipped for everything. Appropriate cases such as early acute appendicitis, non-complicated appendicitis, abscesses can be managed there. We want to look at to see how that model compares to the standard model of resident care here at the medical center. So I'm sure there are a few other projects I missed, but certainly if there's anything of interest within pediatric surgery or pediatric trauma, get in touch with Dr. Schwalls or myself. Thank you.
Stand, please.
I work with industry, and I'm glad I do. I've learned that the federal government actually can't do all of the medical research in the United States. And while it's true that industry will sometimes do things in a manner that's biased, if you channel what they're doing, and if you watch very closely what they're doing, and you set limitations, then you can take the money that they have and the interest that they have and channel it into something good. So one of the biases that I notice that all youngins come out of school with is that industry is bad. Industry is not bad. Industry is just trying to do their fiduciary responsibility, which is provide profits to their shareholders, which includes your mother and father who have mutual funds. So industry is not bad. Just want to make that point. The other point I want to follow up on is actually Dr. Yu's point. When I went to do my fellowship in critical care, really I just wanted to try to be a good doctor, play a lot of basketball, and date women. That was really the main goal. I had no interest in research, zero interest, less than zero maybe. And then in my fellowship I had to do research, and actually I got really interested. And then in my first position, which was at a university-affiliated community hospital, I began asking all these research questions that nobody else was asking or could answer. And then one thing led to another, and oh my God, now I'm drowning in research. So if you don't think you have an interest in research, that's normal. Don't be surprised if there's some hidden interest that lay within you that you won't know about unless you look into it. That's my point. Dr. Mackey begged me to do research a few years ago, so I decided to try to ramp it up a little bit. And we've done quite a number of projects. The two that stand out right now, about $1.3 million in funding, is this very novel sepsis biomarker, soluble CD14 receptor, that the Japanese have figured out how to analyze in a rapid manner. So that's the difference. We've always known about CD14, but nobody could analyze it. And now we have a test for it, and we're 1/3 of the way through, a little bit ahead of schedule, to
between here and the Leahy Clinic and enrolling over 200 patients with sepsis or SIRS, using this as a discriminator between the two. And then the other study, as a follow-up to Nicole Sauer's outstanding presentation, is this invasive intravascular device by Optiscan. There are about half a dozen companies in the world that have really pursued the idea of continuous glucometry, and this is the first company that is ready for prime time and has made their way back to the United States, the purpose of which is to do an FDA pivotal trial. Everybody else is testing the waters and so forth, but nobody has stepped up to the plate and been ready to test it and take it to the FDA, and that's what we and 2 other centers here in the United States are doing in a study that just started in April. There's a bunch of other studies that are ongoing or that we've initiated. There's a couple I don't even have here yet. To his credit, Dr. Blea stepped up to the plate. This question of whether we should be giving alcohol as a drug to people in the United States is one that is entirely unstudied. And so we've decided to do a nationwide survey of academic medical centers to really determine really how is this used as a drug and by whom. Thank you very much.
Is Larry here? Dan, you want to say a couple of words?
Sure. Good job, Ian. We're still. I don't have any slides, I guess. There are, at least I have 3 ongoing projects myself, and then I think Larry has some basic science collaborations that he's working on that I don't know much about. But as far as my projects, I've got an IRB approval for a study, a retrospective analysis, and then there's going to be a prospective component looking at anti-reflux surgery for patients that have laryngopharyngeal reflux disease, trying to sort out predictors of success in those patients who have basically atypical GERD symptoms, and that's a collaboration with Tom Carroll in the ENT department. And then sort of unique to my role, sort of bridging the cardiac and thoracic world, is looking at the implications of lung pathology in the VAD and heart failure patients. So one study is looking at PFTs as a predictor of postoperative complications in VAD patients. Another is looking at the implications of CT scans and radiographic abnormalities in these heart failure patients that are being evaluated for transplant. And both of those are retrospective observational studies looking through our large database here at Tufts.
Rick? I guess you have some orthopedic studies?
Yeah. I think there's a single slide here, Ruben. Which one do you want me to do? Yeah, so here's just a single slide summarizing what we're looking at in transplantation. For various reasons, it's been difficult to maintain certain research issues. But in the past, I've had a project in liver regeneration. This was doing autografts of a pig equivalent of a left lateral segment of a liver to find the salient factors for anatomic location and for growth of liver segments for a transplant model. This was mostly done with foreign fellows, actually, who came previously, but could be resurrected at any time, and there still is a bit of residual funding for doing that. It's a large animal model. Unfortunately, it requires a lot of work, and it's kind of hard for individual surgical residents to take out enough time, given the way the residency is structured, to do that. I also had a project, human project, in the innate immune response to hepatitis C regarding the toll-like receptors that these single-stranded viruses trigger. That one would be basically impossible to resurrect here since we're not doing liver transplants now. But if anyone has an interest there, I'm happy to kind of mentor them in that direction. Right now, as mentioned in the grand rounds that I gave a couple months ago, my current main interest is in a resource allocation and kind of the systems modeling for kidney allocation. We currently pay so much attention to how do patients do after their transplants, kidney transplants. But what we ought to be looking at is how do patients do once they develop renal failure if there's someone who's healthy enough to have a kidney transplant? So backing up the analysis a lot. And I think if we focused on that rather than transplant outcomes, a lot more people would get transplanted. So it's going to involve Markov analysis, and the CTSI will likely be involved. Certainly Steve Pauker of the decision-making group here, and probably I think Peter Newman as well. Dr. Cooper has had in the past some interest in looking at the function of donation after cardiac death kidney grafts. Wrote one of the early important papers there, and there are many ways of looking at that. Going through the national database on in kidney transplantation, and in addition, based on some studies he did and some continuing interests from his lab year between PGY 3 and PGY 4 year in residency, there's this protein 820 which is involved in the regulation of nuclear factor kappa B and the effect that has on cytokine production in cells. So it's a protein where there are several SNPs, and looking at SNP analysis. This is drawing blood tests from patients with kidney transplants, seeing which SNPs they have for A20, and trying to assess how their risk for rejection later on or response to rejection treatment turns out. So that one's still ongoing and can be looked at. Finally, just one other thing. In my role involved in some of the quality work for the department, morbidity mortality meeting and all the rest, and Jeff's work with the residents and the need now, as I think you all know, for being involved in QI type projects. There's this upcoming meeting of the NESQIP movement down in New York. Eric and I have talked about this, Dan Wiener, and I really think we need to have in-house command of how you access the NESQIP database with ends of hundreds of thousands to be able for residents to ask questions almost across the board on the clinical side. And so I'm hopeful that that will be something that starts to bear fruit as soon as this fall. Thanks.
Well, research is important. We love to do research in the trauma division. We'd love to mentor you, and we hope you'll join us. We have the platform. We have ongoing projects. The fruits are hanging there on the tree. You need just to come and pick it up. So I'd like to show you our track record in the last 12 months, and with the hope that we'll attract more people to go to trauma, acute care surgery, and certainly doing research. So it's been a good year for us. We had 9 peer-reviewed publications during 2013 and 2014, mostly in the Journal of Trauma, also Scandinavian Journal of Surgery, American Surgeon, Neurocritical Care, and others. So 9 peer-reviewed publications. We have 3 ongoing studies that 2 are being written right now, and the other one is at the phase of data collection. We had 2 residents so far involved. Vlad was one of them, and now Ravi is working on the second paper. And again, we invite you to join us. We had 13 presentations, 5 of them at the national level, including several at the American Association for the Surgery of Trauma, the Clinical Congress of the ACS, and others. We had 1 international presentation. We had 3 regional, including the New England Surgical Society. We presented 4 grand rounds outside of Tufts, a total of 13 presentations. Future studies that we are going to launch shortly, and discussions are underway. The first one is NTDB. It's a national trauma data bank, more than about 2.2 million patients in that, in which we'll review the injury patterns of cyclists. The second study will involve also Dr. Royer and Dr. Mackey, in which we will evaluate all the classification of technical errors in our department as a study hoping to challenge or confirm that we're doing the right way we classify appropriately. Third study, also NTDB based effort, will examine all self-inflicted abdominal stab wounds. We had several of them, as you probably know. Many of them have significant injuries. Another study is the AMA patient. This is a study that's done as a part of the Level 1 Trauma Collaborative in Boston, in which we want to know, do AMA patients have good clinical judgment? When they leave, do they have a recurrence, recidivism? Are they readmitted to another hospital? So this is going to be an interesting study. And the last one is also, I think, an interesting study. We want to know how accurate are the trauma scenarios on TV. Does the public get the right perception of trauma? When they come, they always bleed. When they die, they always bleed from the mouth, etc., etc. Do they perform ATLS, etc., etc.? So this will be another interesting study. So again, I invite you to join us. And with this, we'll move on to vascular. Is Mark here? Anybody from vascular want to say a couple of words?
I don't know what Mark's, did he prepare any slides or not? No. Okay, I'll say just a few words about my own interest. This past year I've worked with a bunch of medical students, and we've had 2 publications, one in the Journal of American College and one just accepted to the Journal of Arthroplasty on readmission rates. So some systems research, large-scale case-controlled studies of readmitted versus non-readmitted patients, looking at correlates of readmission to the hospital. As you know, readmission rates are a hot topic. These were done by Tufts medical students in their 2nd and 3rd years, and both were published, or both are in press right now. The Journal of American College of Surgeons paper will come out in the next month or 2, and the Journal of Arthroplasty one in October, I believe. My large-scale project that's going on right now is on the progression of asymptomatic carotid disease. We have about 700 patients in our vascular lab who've had vascular lab studies revealing moderate carotid disease, that is 50 to 70% stenosis. And we're looking at correlates of progression of that disease. This is a study that's been ongoing now for 3 years. We've finally gotten the funding for medical students to complete that, but we would be interested in having residents involved. Mark Iafredi is the national principal investigator for a large clinical trial of stem cells for patients with non-reconstructible vascular disease. This is using autologous bone marrow-derived stem cells, processing them, concentrating them, and injecting them into ischemic limbs in the hopes of generating neovascularity and limb salvage, wound healing, and so on. Mark ran the pilot trial for the National Institutes of Health on this and actually found some very surprising results, that pain relief and limb salvage were higher in the stem cell treated patients. This has always been kind of pie in the sky, these stem cell projects, but the pilot of this actually had positive results, and so there's now a national multi-center pivotal trial co-sponsored by the National Institutes of Health and Harvest Technologies, which is the company that derived the hardware for isolating the stem cells. That trial is a very large trial, and I don't know that there's much opportunity for resident involvement at this point since it's underway, but certainly there would be some interesting investigator initiated sub-trials of this that could look at wound healing and so on in these patients. Jim Estes, is working on several large database trials, both involving the national inpatient sample and the NISQIP data now. So there's a lot of opportunity there to get involved in some large-scale database trials. Noah Rosen is concentrating his work in wound healing and the wound center stuff. As you know, we have a huge database on wounds of various types, diabetics, the effect of hyperbaric oxygen on those wounds, chronic venous insufficiency related wounds, and there's obviously opportunity for resident involvement there. I'm sure there are other projects. We're always open to development of smaller scale projects, chart review kind of things, observational studies, and if you have ideas, please come talk to us. Thank you.
I'm working on some QI projects for DVT.
Oh, that's right. I forgot. I'm sorry.
So that would be a good, relatively easy QI project.
Yeah, Jim has been
DVT screening and DVT rates in the hospital.
Jim has been very instrumental in reorganizing the DVT prophylaxis programs and the DVT diagnostic algorithms here. So that's a very fruitful area right now because, as you know, hospital-acquired DVT is a major public health problem.
Okay, this concludes that part, and now we're coming to the fun part of this morning. So we'll have 3 groups. Please come in. And Sandy, maybe you want to let them sit here. We need the PGY3s, PGY4s, PGY5s with the vascular fellow, Joseph, if he's here. So please come.
We don't have any teammates.
I'm sorry?
There's no other PGY guys or fellows. We invite you to join the threes.
Okay, yeah.
PGY threes plus Nicole?
Thomas is here.
Christoph.
Oh, it's Chris. Oh, so where is Thomas? Okay, so, oh, he gained weight, I guess. Okay, so let's do the PGY 5s plus 4s, or maybe you want to supplement the PGY 3s.
Sounds good.
Okay, will be the reinforcement.
Okay, let's go team. Go team.
By the way, there is an incentive to answer, to win it, because each of the participants will get a $150 worth certificate, legal seafood. So you can use it wherever you go.
$150? Okay, you guys are
Yeah, so there's a good reason for you to...
Wait, is this... Maybe you should be girls against boys.
I get kicked out of that group.
Sorry, I make a proposal.
You just made $150.
Okay, so we run it, for those of you who were here last year, it's going to be the same pattern. There will be images. You'll be shown the image, a short description of the case, and then we'll ask you for an answer. And if you, on this case, you know, a 52-year-old female, you see her the epigastric stab wound, she's hypotensive, she's tachycardic. The question is what to do next. So obviously the answer is you take her to the operating room. That's the right answer. So if you get the right answer, you get plus 1 point. However, if you get it wrong, you're getting minus. So you have to be very careful before you kind of jump.
And after we buzz in, can we discuss amongst ourselves?
Yeah, you'll have time. You have time. It's about one minute time for you to discuss. Okay?
You raise your hand.
Okay, and it's first come, first served basis. Whoever raises his hand or her hand first gets the right to talk. Okay, so are we all ready, teams?
No. You raise your hand and then you have time to discuss.
I'm sorry? No. Once you decide that you have the answer, then you raise your hand.
Oh.
But you have one minute to discuss, but remember that they may have found the answer in 30 seconds. So, okay. So teams are ready? Andy, Andy, you sure you don't want to move back? Okay. Just giving you the option. Okay.
They kicked me out, it's all right.
Okay, so this is a 3-week, okay. Nicole, what's the...
The treatment of this condition is a pyloromyotomy.
There are two, the pediatric surgeons insisted that there are two things that you need to do for the patient.
Oh.
Yeah. No. Okay. Because, no, I should have said it, I think, up front, because this is part of the right answer. Therefore, I give Nicole the chance to go ahead.
Fluid resuscitation and laparoscopic pyloromyotomy.
Got it right. Okay. Okay.
Now they're going to say
That's the only question. That's the only question, by the way, that has two answers. So from now on, one answer. This is a 23-year-old male. Our patient, he had a laparotomy for a gunshot wound.
Component separation.
Got it right. Okay. So we are a tie here. Okay. 35-year-old female presented with 1 day of abdominal pain and tenderness. Pre-op diagnosis of large bowel obstruction is made. Patient taken to the operating room, and that's what you find. What? Can you? You're right, but you have to be a little bit.
Hey, you get a minute.
Yeah. Bascule, that's the right one. So -1 here, +1 here. The answer is indeed a bascule. As you know, there are two types. The organoaxial and the bascule, in which the cecum is flipped up. Okay, the treatment is usually either cecectomy or right hemicolectomy. It depends on your findings. 57-year-old guy. Yep.
Pulmonary embolectomy.
Okay, this was fast. This was fast. It was everybody's patient. That's why it's fair for all groups. This was a case with major PE that had an open embolectomy by Dr. Warner. 55-year-old man, CRF, secondary to Alport syndrome, on hemodialysis versus left arm, AVF for 8 years. He had a kidney transplant in the past ×2 during 20 years. Vascular rejection after the second transplant required intense therapy. Now he's on the drugs that you can see, and recently noted new lesions over his fistula. What is the diagnosis? Nicole?
squamous cell carcinoma.
Damn.
Rick,
you want to say a couple of words?
Just that all in the picture there, all those white spots over the fistula are innumerable scars from needle puncture sites over the years for his fistula. And with the immunosuppression he's on, the risk of skin cancer is much higher in patients on immunosuppression. So he developed a scar carcinoma over his 18 years.
Okay, thank you. This is a 72-year-old guy after a car crash in the ED, is hypotensive, has a positive fast. Yep. Got it right. Okay, you can see here, there's a nice demonstration. You can see the duodenum flipped by the finger. You can see the IVC clearly next to it. You can see the colon, which is retracted by the left hand. And you can see the central retroperitoneal hematoma for which the patient was explored. "57-year-old male with 7 out of 10 diffuse abdominal pain and distension. CAT scan of the abdomen is done and shows the following." Yep.
SMV thrombosis?
I'm sorry? What did you say? SMV thrombosis. Got it right. You can, Dr. Mackey submitted this slide. You want to?
That was easy. I didn't divulge to anyone.
You want to say a word or two on?
No, that's the right diagnosis.
Okay.
We're tied 3-3.
Okay. So we are 3-3, I'm told. So, we have 3 more questions to go. Tension is rising, I see. 55-year-old, otherwise healthy male, presented with back pain for 5 months and lower extremity swelling for 2 weeks. Lower extremity ultrasound was negative. MRI and venogram showed the following. What is the most likely diagnosis in this case? I'll give you a hint. This is Dr. Goodman's slide. Yep.
Retroperitoneal sarcoma?
That's the wrong one. I'm sorry?
Do we have to answer?
Okay. No, okay. It's IVC sarcoma. This is a case that he did. You can see the specimen ex vivo and in...
The IVC is in the retroperitoneal.
Hey, we got single volvulus was up there too.
It's
I
in,
think we should ask Dr. Rothschild, the interventional oncologist, if this is correct.
That's not the same diagnosis as vascular volvulus, but that's a good
so you I'm just okay. Martin is not here, but he made it very clear to me that the answer should be IVC sarcoma, not retroperitoneal sarcoma. So, and that's the case. So I would stand by him. Sorry, girls. Okay. 68-year-old obese patient with hypertension, presented with acute severe chest pain. Diagnosis of MI is established. He goes emergent catheterization, which shows the following. What is the treatment for this patient?
Is that cabbage?
You're asking me or you are answering?
The answer is a cabbage.
Answer the cabbage. Well, got it right. And there are very few indications left for cabbage, and the cardiac surgeons are not here, but I'll tell you. One of which is obstruction of the left main, which you can see here. The other one is two-vessel disease. If one of the vessels is a proximal LAD, more than 70%. So you got it right. What's the score?
4-2.
4-2. So, okay, we have a winner here, but let's see how you'll do here. 75-year-old, past medical history of right lower lobe resection for lung cancer. Presented with abdominal fullness. CAT scan is done, which shows the following. What's the diagnosis? Yes.
All right. How about metastasis to the adrenal gland?
Okay, that's the wrong answer. This is Dr. Graham's question, and he's not here to describe it. It's not my field. Anybody want to try here? On the male side? Okay, well, I think that concludes everything. Thank you all very much.